Good afternoon, everybody. My name is Garrett Schmidt, and I'm the managing editor for ACOexhibithall.com. And I would like to welcome you to today's webinar. It's hosted by Innovista Health Solutions. And this is a case study debrief, and it's titled How Physician Engagement Can Drive Real Change in a Medicare Advantage Population. And I'm very excited about this topic. I think it's going to be something that's very interesting and informative to you all. So a few items of note before we begin. Wanted to let you know that all attendees have joined the webinar today in listen-only mode, so you don't need to worry about muting your mic. That will be done for you. I would like to let you know that the webinar is being recorded, so we would love for you to watch it afterwards or send it to colleagues and etc. So I'm going to afterwards send each of you, and actually everyone that's registered, whether they're able to make the presentation or not, a link to the recording, and there will also be a place where they can download the presentation slides as well. And finally, during the webinar, we want to hear from you, and we want to answer some of your questions. So please submit your questions using the attendee control panel. There's a little area for questions on there that you can ask, and you can do that at any time during the presentation. You don't have to wait till the Q&A at the end, but we're going to have some time to answer those questions at the end of the presentation. And these are also being recorded, so if we are not able to get to yours for some reason today, we'll make sure to follow up and answer via email. All right, well, without further ado, our presenters today from Innovista Health Solutions is Mr. Selase Dow, who you can see here on the screen is North Texas Market President, and also Ms. Crystal Ekton, who's the Central Texas Market President. She's going to be joining us a little bit later to answer some of the questions at the end. And I believe Mr. Dow is going to get us started, so welcome, Selase.
Thank you, Garrett, for the introduction, and welcome everyone to this webinar. We appreciate you taking the time out of your day to spend some time with us on this case study. As Garrett indicated, it is a case study about how physician engagement can drive real change in the Medicare Advantage population within a partnership with Innovista and one of our ACOs in North Texas, Genesis Physicians Group. A little quick introduction about myself. I'm the market president for Innovista Health Solutions in North Texas. And if you're looking at the screen, I've got 16 plus years in the population health environment, primarily specializing in health plan operations, strategic planning, startups, and growth and expansions. As Garrett also indicated, Ms. Crystal Ekton is on the call as well. She will be joining us when we get into the Q&A session. Ms. Ekton has a BA in economics from UC Berkeley and has been in this industry for 10 plus years, specializes also in health plan operations, strategic planning, growth expansion, and then startups. So thank you for having us. We will get started. I want to be able to introduce you to our Genesis Physicians Group. The Genesis Physicians Group has a ACO environment or ACO subsidiary called the Genesis High Performance Network. This is a group of primary care physicians engaged in value-based contracts that focused on improved quality, reduced cost, and high patient satisfaction. GHPN, as we call it, is comprised of PCP members, and they are part of North Texas' largest and oldest IPA. We at Genesis believe that the independent physician organizations have an important role to play in the future of healthcare delivery for Texas. And our mission is to champion our physician for their passion for the profession of medicine to achieve high quality, cost-effective care for the patients that we serve. On the right side of the slide that you're looking at, I wanted to be able to show some of the elements of Genesis High Performance Network. They've got about 250 practices, 300 plus physicians. We currently have about 71,000 lives under management within the ACO infrastructure that spreads across both Medicare fee-for-service in the Medicare Share Savings Program. It also includes commercial products, Medicare Advantage products, and Medicaid products. And then in the last 2 performance years that Innovista has partnered with Genesis, we have made upwards of $7.35 million in shared savings that have, and certainly some of it have been distributed to our physician population. Now, Innovista Health Solutions is an MSO. Our mission is helping providers succeed in value-based care by developing strong relationships, delivering innovative solutions, and driving exceptional performance. Innovista was created as a service partner to help physicians and medical groups respond to the value-based shared risk payment models across healthcare landscapes. Our solutions that we deploy, Innovista is a certified management service organization and licensed third-party TPA dedicated to working with independent physicians to drive success in programs, as I mentioned, within the MSSP, commercial, Medicare Advantage, and Medicaid space. Dr. Jim Walton is the CEO, and the far right on your screen, you can see some anecdotes as he reflects on the partnership between Innovista and Genesis. And I quickly read through that. The benefit, according to Dr. Walton, that his organization has seen through the partnership and Innovista has been centered around physician-centric approach to value-based contracting and population health service development. Innovista has proven to be flexible and adaptive to the environment of working with well-established messenger model IPAs, helping to transition capabilities to include effective patient-focused and practice-focused services simultaneously. So thank you, Dr. Walton, for that anecdote. On this screen or this slide illustrates sort of the value-based care roadmap. So Innovista's support of independent physician ACOs falls across the spectrum, whether that ACO is in the fee-for-service environment or has sort of leaned into the pay-for-performance environment where it is not just fee-for-service, but also some incentives for quality measures and quality incentive program. And then we do support ACOs in the shared savings environment as well. And then certainly on the far right, the more mature risk arrangements is an area that we thrive in. Across all of these value-based roadmaps, Innovista deploys a list of supportive instruments, both for administrative management as well as population health playbook strategies. So from network formation to governance and contracting, across medical economics, network configuration, quality management, through compliance, eligibility management, claims payment, customer service, utilization management, disease management, we deploy all these tools and infrastructure to support our independent ACOs thrive in this space. And then we do support them with financial management, IT infrastructure, data management, analytics, and reporting. These are all very integral to the success of an ACO, or the ACOs at least that we partner with. So what is this case study about? Well, it's about an ACO that Innovista partnered with that has some challenges that we thought we could help them mitigate. We started with defining the problem. This case study begins with the challenges that that Genesis faced. Once we were able to define the problem, we began to put together solutions. Given the challenges, this case study will explore the various targets and the various approaches that we deploy to mitigate the issue. And then we had to define the results. We had to measure it, we had to quantify it, and be able to let the ACO know what the results look like. So this is what this case study will seek to explore. The problem as we saw it was back in 2017, Genesis had a single ACO value-based contract, and it was struggling. These are the 4 areas that we saw some of the challenges in. ER utilization, which is emergency room utilization, medication adherence challenges, coding gaps challenges, and opportunities for enhanced physician engagement. So once we identify these issues, we began to pull together solutions to help Genesis mitigate them and be able to be successful in this particular value-based initiative. The emergency room utilization, when we first began to look at it, was way above the target. Genesis Physicians Group had an ER per 1,000, which is the normalized metrics that this industry uses to measure ER utilization, was about 1,500, certainly nearly 5 times what our target internally was at Innovista, which is 325. Some of the reasons we identified for this high ER utilization was chronically ill patients with limited access to primary care, immediate care and wide variety of healthcare options and poor benefit design, number of specialists in the network that were, porous network, a lack of connectivity, so the members were going out of network and selling into the ER emergency rooms, chronically ill patients with limited care coordination, moderate and non-existent provider-patient relationship, and then certainly limited, in some extent, limited after-hours care for these members. So we were able to identify these issues that were driving that high ER per thousand. The other problem that was defined was the medication adherence environment. We know within the Medicare Advantage space that it drives star ratings. It is a triple weighted measure. And so we were able to figure out that the issue existed with timely, the patient's ability to obtain medication in a timely fashion, and then the patient's ability to self-direct and adhere to the schedule or guidelines provided by either the primary care physician or the specialist. And this is important because, again, it drives star rating for the payers. It drives star ratings that supports Medicare Advantage plans be able to also thrive within the space. The third issue that we identified was coding gaps. It is a low-hanging fruit within the Medicare Advantage space, and really at the beginning of 2018, our partner, about 90% of the providers were not coding to the highest level of specificity. They weren't identifying year over year the acuity level or the burden of illness of their patients, which is important because that is what drives the resource allocation to be able to manage those patient population. In the same time frame, which is early 2018, about 95% of providers were not submitting the appropriate number of codes. Most of you know that you can submit up to 12 when you submit claims up to your payer partners or certainly to other stakeholders. And so we were able to define these and bring in the SMEs, the subject matter experts, and the resources to be able to help physicians close their knowledge gap in coding and risk adjustment. The final area that we identified was physician engagement opportunities. None of these happen effectively if we don't get physician engagement across all spectrums. Physician engagement with patients, with the ACO leadership, with the human resources that we deploy to help them thrive in this space. And so that became sort of the areas that we wanted to focus on. In the next couple of slides, I'm going to talk about what specific solutions we deploy to help solve these challenges. Network stabilization, care management programs, and leveraging our proprietary technology platform. We had to be able to put something in front of our physicians and our partners so that they can analyze, quantify the issues, and be able to deploy solutions through technology to our physician population. Innovista sought to stabilize the network through a combination of physician engagement, ER utilization mitigation, and a specialty network management. The primary method that Genesis and Innovista used to stabilize the physician was based on conducting an assessment to determine the root cause of what was driving these challenges. And so we deployed staff to the physician offices. We have staff that go into the practices on a monthly basis to assess what's happening, practice design, what are the challenges, and what resource we can deploy. And once we were able to identify uniquely what was impacting each physician practice, we're able to deploy specific items that will help them solve their particular issues. There were audits that were done, and that helped us deploy those solutions that I'm about to talk about. First, patient engagement. So programs, we wanted to define and set up programs that allowed us, certainly with the support of our physicians, to engage our patients, enrolling them in our case management programs, high-risk case management, transitional care management, we deployed a campaign called Call Your Doctor First, which provides education both for the physicians and their staff, as well as the patients, to reach out to their physicians if they believe they were running into some health challenges. Now, that doesn't warrant a member to go into the ER if they think they're having a catastrophic event that needs them to get into the ER. But for the most part, we wanted to deploy the culture of a member engaging a physician first, where appropriate, to solicit support from the physician before rushing off into the emergency room. So this Call Your Doctor First campaign gives both the physician practice as well as the member guidelines to follow if they needed support for a medical issue. We identify some of the barriers within the practice as well in terms of triaging cases and making sure that they had some open hours within their schedule for members to be seen, as opposed to them going to the ER. In the medication adherence space, identify those patients that needed support to remain compliant. We used our technology tool and big data to determine who the members are, where they were in that compliance environment. We partnered with both the physicians and the payers to deploy some of the benefits that the payers provide. 90-day supplies at none or zero cost for the members, so they can remain compliant for an extended period of time. And then we had our nurses and LVNs engage these patients on a regular cadence to enroll them in appropriate programs, to engage them and support them through this process. Our case management environment did not only focus on transitional health care or high-risk member care or enrollment, we also focused on social determinants of health. This is an area that we know is vital, because if a member cannot have social issues or social challenges, oftentimes they're not focused on their health. They're focused on trying to put food on the table, trying to find housing, trying to find transportation. And so we focus on that as well to make sure we can support them in that environment, so that they can be partners with us in trying to manage their chronic conditions. And then our nurses try to coordinate with the members to see specialists, to see physicians. We have nurses that are embedded in practices so that they can build relationships with the physicians as they work to support their members. Technology is an integral part of what Innovista does in partnership with our ACOs. We leverage it quite a bit to drive data into the physician practices, to drive analytic research into the physician practices. We deploy a tool called 360. It's a ribbon that sits on the physician's EMR and gives them a really clean line of sight as to which members are being admitted, which members are going to the ER, which members are enrolled in high-risk case management, which members need HCC gaps closed, which members need quality gaps closed. And so this tool has been really instrumental in the success that Genesis has achieved in the past 2 years. Our 360 environment also is able to stratify our members using the Johns Hopkins ACG model to determine who are the high-risk members, as well as who are the high opportunity members. It supports risk adjustment audits within that tool. It supports HCC audits within that tool. And all of that information is available to the physicians at their fingertips through the point of care tool that sits on their EMR. So there isn't a time where a member will walk into a practice and physician not be able to know what the entire picture of the member's care. It gives them a better line of sight, and it gives them better control when they're trying to support the member in their disease management. Now, we measured the results. So since 2017, Genesis has seen a radical shift in performance and shared savings through the implementation of the care management programs, the technology that I talked about, as well as the physician engagement tactics. We've seen some results, real tangible results in the ER utilization environment, the readmission rates, risk adjustment coding, and the savings and medical loss ratio that we measure ourselves by, but that supports us generate shared savings for our physician population. I'd like to talk a little bit about the emergency room department utilization results. Emergency room department ADK, as we call it, or admissions per thousand, which is the normalized way to look at a population emergency utilization numbers, fell by 70% from Q1 2018 through Q1 2020. Genesis saw a reduction from 1432 ERK to 421 in the span of 2 years. Improved patient and provider engagement fostered the relationships critical to the reduced use of emergency services in instances where the cost of care is uncertain to the patients. The graph on the right of your screen here really depicts what we were able to achieve for this group. Certainly it produced cost mitigation, but it also produced quality of care. You know, some members don't want to go into the ER all the time. They want to be able to access care through their patients and their specialty and their specialists, and so as well as their case managers and their other clinical staff that support them. And so through this education and engagement of the physicians, we were able to reduce it, and we saw both the tangible numbers in cost mitigation, but the quality of care improve for our patients as well. Readmission rates. So hospital readmission rates fell from 24% at the start of the performance year in 2018 to 6% at the end of 2019, surpassing the Medicare Advantage goal of 10%. Again, on the far right of the screen, you can see some of the achievements quarter over quarter, currently hovering about 6%. That is real tangible results. That is results that our ACO appreciated, our physicians appreciate, and our members and patients appreciate as well. Hospital readmission was drastically reduced due to the implementation of the TCM program, as well as the high-risk management program. Innovista's population health management platform connected providers and their patients to the network and ensured that our patients were staying in network, that our physicians had a line of sight as to the members that were high risk so that they can deploy in partnership with us the kinds of care that those members needed in order to mitigate avoidable ER utilization and subsequent admissions. A risk adjustment and coding, as I said at the top of this webinar, is certainly a low-hanging fruit. It is really important. The first part of it is that you need to be able to make sure that you are actually capturing the acuity level of your population, the burden of illness within your population. And so Innovista deploys SMEs in this environment as well. Coders that know risk adjustment, they were able to design tools that were easily ingestible by the physicians. They were able to design coding engagement collateral. They were able to provide physicians with feedback about how to code to the highest level of specificity. They are deployed on a monthly basis into the practices. They do audits of charts so that they can support physicians on a year-to-year basis in doing this work. They also our staff also partner with payers to ensure that we're deploying what we call revalidation tools. Payers on an annual basis are requiring physicians to revalidate these chronic conditions, and they supply their own tools and documents. So we support the payers in engaging the payers to do this work as well. And then, of course, report all those results back to payers or to CMS so that we're able to capture the appropriate burden of illness and acuity level of our population, which drives the resources that come through to the ACO to support these members. By the beginning of 2019, 70% of our providers were coding to the highest level of specificity. They were very excited to join the webinars, excited to meet our coders. In fact, that was probably one of the areas that they really enjoyed because they could really see those results, those tangible results in real time. If you're documenting appropriately, then you're going to see your burden of illness score or risk score go up appropriately. Again, I stress on the word, it's got to be appropriate. and you're going to see the resources that you need to support those members. And so we saw the risk score move up from 0.98 to 1.11 by the end of the performance year in 2019. On the far right, you can see a graph that showed where we were back in 2018 and where we are, where we ended up back in 2019 in terms of providers sending the appropriate number of codes through claims environment. One of the key elements of our platform is that it's able to tell physicians on a month-to-month basis the coding gaps that they have. So what they're being given credit for by the payer, our tool is able to tell them, and then the physician is able to engage and close those gaps and send the appropriate number of codes up to the payer. And then finally, how were we measuring ourselves? Well, savings and medical loss ratio. It is a payer's evaluation on how much, if you look at revenue coming in versus expenses going out, what is your appropriate net? And so it's important because it allows us to re-incentivize our physicians, give them what they deserve, which is shared savings for them to continue to support their practices and their pool of members. Between, in performance year 2019, from 2018, we drove the share savings up by 40%. And the graph kind of shows that. You can see in Q1 18, an MLR for this particular product was at 122%, and by Q4 of 2019, it was at 82%. MLR is directly impacted by engagement. At the end of 2019, engagement with primary care physicians was over 7%. Getting that ER utilization under control, driving the risk adjustment program, and better understanding the engagement and the high-risk members all contribute to the savings. So it isn't one thing, it is multiple aspects, but it really stems from Innovista's work with Genesis, our partnership with Genesis, the physician leadership, the staff and the resource, the technology platform, and how we deployed all of that into the practices. These are the elements that drove these really good results for this ACO. All right. Looks like we've come to the end of the presentation. I will yield back to Garrett to drive the QA session. My counterpart, Crystal Ecton, is going to be supporting me in this QA session, and hopefully we can flesh out some additional questions that may come from the audience related to what I've just gone through. Oftentimes that drives more really interesting discussions and provides some context to some of the webinars that we've done in the past. So Garrett, I will yield to you for the QA session, and Crystal, welcome on board.
Great. Thank you, Selase. That was great. And welcome, Crystal. We do have a few questions that came in. So in no particular order, I'm going to go ahead and ask these. First one is, how are the case management practices tailored to this specific patient population?
It's a good question. So our technology platform, which is the 360 tool, number one, first of all, is able to risk stratify the members. So we are able to tell on a month-to-month basis and certainly in real time the members that are high risk and high opportunity based on all the data that we get from claims and from public available resources as well. And so our nurse leadership can see really in the system the conditions. If they're high risk with higher opportunity, that's how we engage the members. We've got thousands of members. Not all of them need the services that they need, but it starts from risk stratification. And once we know their level of risk, then our case managers are going to engage that member, whether they're diabetics or they've got CAPD or CHF. We've got specific disease management programs that those members get enrolled in to support their care.
Okay, great. This question came in and it says, can you repeat what Johns Hopkins tool you used for stratification?
Right, it's the Johns Hopkins ACG model. It really takes into account really demographic information, chronic conditions, public available data, and we ingest it. It's built really at the sort of backbone of our tool, but once we ingest the claims data on on a monthly basis from the payer, this this model is able to really, again, re-stratify those members from a risk level of 1 to 5, and then is also able to stratify the patients from a high opportunity of 1, low opportunity of 1 to a high opportunity of 5. And so when you look in this tool, you're going to see the member's name, the member's demographic information, their chronic conditions, any medications they're on, the activity in terms of providers they've seen, facilities they've visited. But it really gives you green and red bubbles. Are they high risk and are they high opportunity? And then our nurses that assign these cohort of members then begin to engage the member and say, okay, based on what we're seeing in your data, you know, you are a high risk member and we've got a high risk case management program for you, or we've got a transitional care program for you, or we've got a medication adherence program for you, we've got a CHF program for you. And really, you know, our nurses are committed. They've got families themselves. They know that this is the area where folks are most vulnerable. And so they bring to the table a real commitment to supporting these members and making sure that we're listening to what their concerns are. So when we engage our members, you know, you may engage a member and know off the bat that they need to be enrolled in a specific program. However, when we engage those members, we're really listening to them. Okay, what are your needs? Is there something that we need to be able to solve for you before we get your commitment to enroll in this particular program, the diabetic program, so that you can make sure you're keeping your glucose level at the appropriate levels. It's a real commitment. It's a holistic approach to patient care. It does have targeted approaches, but it's a really holistic approach to patient care. And the ACG model allows us to really risk stratify them for those purposes.
Great. Next question, and again, in no particular order here, could you go into a little bit more depth on the relationship building that occurred between the providers and the Innovista team, and how is that trust built?
It's a great question. I mean, I believe firmly that certainly within this nation and what we're doing in the value-based space as population health, it is really based on relationships, whether it's a relationship between, to your point, population health staff and PCPs, or between the patient and the member. It's all about trust. We've got to get the trust up there for folks to be able to accept and ingest and partner with us in what we do. So that's where Innovista starts from really in the beginning. We've got staff members that engage physicians really on a month-to-month basis. So they're in the offices saying, what can I do to help? This is the data that I have on your population. This is where I see your opportunities, and how can I help you? We call it giving the physicians headroom. In fact, our Genesis CEO coined that phrase, giving them headroom, because physicians are bombarded quite a bit with a ton of information, and we make it easy for them. We're deploying primarily the actionable data that helps them drive performance and quality of care. So really it's fundamental. Getting a staff member into those practices, building a relationship with the front office, the back office, and the physician. So that's number one. Number two, we've got a strong physician leadership. Our chief medical officer, our CEO are both physicians. And so when our staff aren't able to engage, they're deployed to engage the physician from a peer-to-peer standpoint, sharing the same data and reaffirming that what they're seeing from the coder or the case manager, or certainly myself, is important and is going to drive patient care. Also, they share their own life experiences. You know, again, it's important to have physician leadership because they've been down that road. They've been in those practices. They've been down in the weeds. And so it's important for a physician to hear from another leader about how they navigated those challenges. And our leadership, Dr. Sir and Dr. Walton, they do that effectively. And then more importantly, we have a cohort of physicians, we call them pod leaders, that come together on a cadence to look at this data and come up with strategies to help our physicians. So when I say staff, it's really staff from SMEs that know coding and risk adjustment and provider relations and all the fun stuff, but it all goes all the way up to physician leadership. You need that village to be able to drive performance, and we tap into all of those on a monthly basis to get this done. And our physicians appreciate it. They appreciate that we bring them actionable data. They appreciate that we take away the noise, and they appreciate that they've got some support from a peer-to-peer standpoint when they need that as well.
Okay, great. Next question is, how do you assure providers of the importance of coding? A lot of providers balk at the additional administrative burden in the immediate sense.
You know, that's a really great question. It is probably one of the more complex areas of population health and Medicare Advantage and the strategies that are deployed in that environment. It is another language. That's the way I call it, right? It is another language. You've got to really shut off your regular brain and put on the new one. Our staff make it easy. I'm really proud of what they do in how they dissect the coding and risk adjustment environment and make it easy for physicians or physician staff members to understand this really complicated environment. It starts with building the tools, really easy tools that physicians can see that says, this is a chronic condition, this is the appropriate code, and this is the appropriate documentation to support that code. Again, I keep using the word appropriate because one of the things we teach our physicians is to ensure that they're not upcoding, or they're not coding just for the heck of it. It's got to be a condition that exists for that member that can be justifiable, that can be justified, because all of this get audited. So it starts with developing tools that are easy to ingest. And for any of the audiences that are on there, my contact information is in this deck. Feel free to reach out to me. We can share with you some of the tools that we deploy for our physicians day in and day out. It also, you know, so anyway, we deploy those tools. We have staff members that sit with the physicians or their designee to walk them through how to do it. And if you can start with that process, I think you're going to achieve success. The other important piece is that even though it's very difficult and it's very complicated and complex, I think that's the area that you can draw a line between activity and results. If you're able to code appropriately and document and revalidate the chronic conditions of your population on a month-to-month basis, what you're going to see fairly quickly is the results that generate. It improves the burden of illness or the risk score. It also shows up in your premium, your revenue stream that comes from the Medicare Advantage payers. It's a tangible, easily identifiable result. And so we've used that to show physicians the benefit. So it's not just about doing this work, but it's about showing them where it shows up in revenue streams. That's number one. We also know that you can't control every chronic condition. You can't control, and appropriately so. If somebody needs a heart transplant, they get it. If they need brain surgery, they get it. If they've got to go in and be admitted, they get it. What coding does is you're documenting those illnesses so that you get the right resource to manage all of those conditions. If you don't, then what tends to happen is that you're taking care of those members appropriately. You're sending them to the right providers and the right facilities appropriately, but you don't have the adequate resource to manage their cost of care. And so we explain that to the physicians. We show them that in data, but first of all, we build very simple, easily to ingest tools that makes this work easy for them. And I'm proud of the work that our staff have been able to do in that environment. Hopefully that answered the question from for the audience.
It does. And Crystal, we'd love to hear from you. And I'll pose this next question to you. How has COVID impacted this group's operations, and has their patient population posed any unique challenges?
Yeah, it has. You know, the primary care practices that we typically partner with, they've been hit really hard, not only just from their own practices, just their own revenue, and then a whole nother level of keeping themselves safe as well as their staff safe, and then also being there for their patients. So it's been really interesting to watch, you know, and I cover multiple cities, so each city's been different. Each city's ordinance has been different, and they've placed upon different rules on all the practices. And so the patients as well, they're looking for information. So one of the great things we did, our teams were able to do, Selase Minds, is we shifted quickly, right? So yes, we partner and we build trust for value-based healthcare, but through that you become kind of a family. You become this bigger entity of partners. And so we had the shift on a dime even to kind of change our messaging, right? So instead of calling them and talking to them about quality measure gaps or risk adjustment coding, right? That wasn't the time, it wasn't appropriate. So we switched on a dime actually, and we started to produce and create tools, resources, as Selase's mentioned, to educate the practices, their patients on COVID. How to keep your practice safe, how to even apply for these PPE, how to get PPE in, right? The protective gear, how to get the, how to apply for the loans. So we really just kind of circled around all these practices to educate them and their patients to get them the right care.
Yeah, that's great. And this is a question that I find very interesting is, were you able to affect any increase in telehealth for the Genesis population?
We were. I mean, I think one of the things we've noticed is that what the pandemic has done is some of these, what we know is important, right? Telehealth has been in the periphery for a long time, has been discussed in multiple forums, but it hasn't really taken off. What the pandemic did was all of a sudden, it was a no-brainer. You've got to do it. The federal government issued policies that expanded the reach of telehealth and the tools that can be used for it. The payers and the health plans were really publishing how to do telehealth, what you need, how to bill for it. I mean, this was our lives really marched through, and it is our lives now, because we know that we're seeing the viral spike. We know that members aren't going into the practices as often as they've done historically in a traditional year. This is not a traditional year. And so we've seen, I would say an 80% jump in the use or the attempt of use of telehealth. And folks are still learning about it, right? I mean, physicians are still trying to figure it out. But I know that between March and now, we at Genesis are seeing an 80% engagement in the use of telehealth. And we continue to support, as Crystal says, support the physicians do this work. Because one of the questions that comes up, okay, there's the tool I need to use, this is how I need to use, how do I bill for it, appropriately for it? And so our staff developed, to Crystal's point, when the pandemic hit in March, we had our traditional populational playbook, but we had to really deviate from that to some extent and make sure that all the information that was really coming down at an incredible speed from payers and the federal government and local government, we were deciphering that information, ingesting it, and then making it simple for our physicians to ingest. Part of our success at Genesis and certainly in Crystal's market is being SMEs. We take that information and burden, and then we make sure that the physicians are focused on what is important, because among all that information, there's a bit of noise. And if you just pipe that information without reviewing it to the physicians, it creates more of a burden and a roadblock as opposed to helping them out, really focus on what they need. So PPPs, PPEs, telehealth utilization, all of those stuff, coding, COVID testing environments. I mean, we took some time, really months, to do this work for them and then give them really the information that they needed so they don't have to spend time looking for it themselves. And what is done is that our practices and our ACOs have thrived. They've been able to sustain their staff. They've been able to remain committed to this work. And we're all waiting for this pandemic to be over.
Great. We've got time for one more question, and I'm going to pitch this one over to Crystal. This one is, in terms of provider engagement, are your provider partners willingly and consistently screening their patients and on the social determinants of health?
Yeah, it's something that we've been focusing on. We started off the year focusing on that, and then the COVID hit, and that's very distracting for a lot of reasons. But it's an extremely important part of how we identify, right, with social determinants. So right now, in the lull of the practices really having that ability to hone in on that, our care management team. So Selase went through all the different things that we do, but one of the most important things I think our care management team does is when our nurses reach out, they're determining that, they're learning and asking questions about, you know, their living situation, who provides care to them, do they have money to buy food, do they have transportation, and also through that with all the COVID education, just seeing, you know, and providing them even information about, you know, where can you get meals, how, you know, how can you get these needs met. So it plays a huge role, because, you know, I'm sure you've heard stories, but, you know, one of the best stories I ever heard was there's this one particular patient who, you know, in the data it showed that they went to the ER probably 15 times that year, and nobody could figure out why. And they just kept going. And finally, when someone sat down and took enough time to fully understand what their living situation, right, like the other social determinants were going on, they learned that that person didn't have an air conditioning unit. And they lived in Texas, so it was really hot in the summer. And that's where they were going. They couldn't be at home. And so literally the ACO bought this person like a $2,000 AC unit, and they never went to the ER again. So it's critical. I know, it's asinine. It's critical to understand what's going on behind the scenes. Why isn't a patient taking their medication? Why are they going to the ER? And a lot of it isn't fleshed out in data, right? You really have to get to know what's going on.
Yeah, I've heard a lot of those stories myself, and it's always amazing.
Right. They're motivating though.
They are.
Yeah.
And great. And well, unfortunately, that's kind of all the time we have for questions today. We did have a couple extras, and so we will make sure to get back to you via email afterwards. Thank you for being so engaged, and thank you both for a wonderful presentation. This is very informative, very helpful. I thought so anyway. And for all of you, I wanted to thank you again for coming. As we conclude, I wanted to encourage you to visit the Innovista exhibit booth at ACOExhibitHall.com, and there's a picture of it here. And you can go there and learn more about them and what they do and connect with their team. And it's a really cool tool for you to use. And also, this is where at ACOExhibitHall.com is where the recording of today's session will be housed. Now, I will email it out to you, a link, and you can get the slides there, but it'll also be available in the reference library at ACO Exhibit Hall. And then lastly, if you have any specific questions for any of our panelists today, and I'm sure you can see Selase's information is down here, and if you have a question for Crystal, I'm sure you can pass that along to her as well, or any of the Innovista team. Please feel free to reach out to them and contact them directly, or you can reach out to me as well, and I'll try to put you in touch, and they'll be happy to follow up with you for further discussion. And so thank you all for attending. This was great. I hope you found today's presentation helpful and very informative. I did. And I hope you have a great rest of your day. Stay safe and stay healthy. Thank you for coming.
Thank you, Garrett, and thank you, everyone. Have a wonderful day.
Thank you both.